Welcome, everybody. It's so great that there are so many people joining us tonight for this endometrial cancer webinar, which is a very important topic for us at ENAGAGE, and especially, of course, in June during the Endometrial Cancer Month. We have a great program tonight with, of course, Maria Papageorgiou. I hope I say this right, Maria. And I did my best. Also with Artem Stepanyan and Houssein El Hajj. We're going to start first with, Philip, would like to say, I'm moderating this tonight with Philippe Morris. Would you like to say a welcome word?
Yes, I'm the co-chair of ENGAGE with Kim, and I'm really happy to chair this session. And as you know, there are a lot of modification during the last month and the last 2 years about the management and the molecular biology and the knowledge about endometrial cancer. So it's very important webinar that we will have currently, because many things had changed during the last month, and ESGO did a lot for this modification. So Maria, we are very happy to give you the microphone to begin this lecture.
Yes, thank you, Maria. Maria will talk about the psychological burden of an endometrial cancer diagnosis. And Maria is the founder of the Greek Advocacy Gynaecological Cancer Patient Group called ERIFILE. Go ahead, Maria.
Hello, everyone. And I want to thank you, Kim and Philip, for inviting me to speak to giving it the opportunity to speak up for a really important issue that is still not easily talked about. My name is Maria Papageorgiou, as Kim said, and I'm a survivor of endometrial cancer. I was diagnosed with endometrial cancer in June of 2011. I had surgery, hysterectomy, at the age of 45. Not too young, not too old, but still in my reproductive years. While I was preparing my presentation, why doesn't sorry. I did something here, sorry. I need help. Okay. While I was preparing for my presentation,
you can control the presentation normally.
I looked for publications on the subject, and I found only a few, and not specific for endometrial cancer. And as one of them said, for quality of life, when considering specific diseases, ovarian and cervical cancers were the most researched. Endometrial cancer was underreported in recent literature. Studies have shown studies addressing vulvar and vaginal cancers are lacking. My presentation is based on my own experience, on my thoughts, and on my, I don't know why it doesn't move. Sorry. On my own experience, on my thoughts, on my research, and the little I found on my research, as well as my interaction with other endometrial cancer patients. I'm going to divide the patients into two groups: the ones that got diagnosed after menopause and the ones that got diagnosed before. In the past, the ratio between those two groups were different from what it is now. At the moment, due to lifestyle, women are getting diagnosed a lot younger, still in their reproductive years. And this is not the only parameter that has changed. Women now live longer, they're active and very much involved with all life's activities. A 65-year-old woman has nothing in common with a 65-year-old woman in the 70s or the 80s or even the 90s. Women who want to be aware and to have a very good quality of life. In the past, even the way endometrial cancer was treated was different. If a woman after menopause had abnormal bleeding, she was going to the doctor, she had a hysterectomy, and she was going back home. No other therapies were given, no subtypes were known, no staging, nothing else. Going back to home, nobody really had to know anything, not even friends or family who wasn't that close. Cancer was not a subject to discuss over dinner anyway, and since usually there was no extra therapies and no visible change, it was like it never happened. Only the women themselves carried the burden and the fear of having this knowledge, and maybe had no one to share it with, to talk it over. They had just to live with it, like nothing had ever happened. This might be a reason why we didn't know much about endometrial cancer. We all knew about cervical, but know about endometrial. But now things have changed, not only because women are getting diagnosed younger, but also because a 65-year-old woman is still young, active, and a productive member of society. And they want to live their life to the fullest and demand this life to be a good one. So they demand the best possible therapy and the best possible quality of life after therapies. Fortunately, they are more talkative and they share their problems and their fears and their needs, and they make themselves and endometrial cancer more visible. Professor Colombo told us that endometrial cancer is like Cinderella's story. And in past times, Cinderella was sitting by the fireplace, not speaking out, serving others, being in the side of life. But now she wants to go to the ball. She wants to wear her princess dress. She wants to be in the center of life, no matter what her age is. Cancer in general carries a big psychological burden. It's scary enough. Death is knocking at your door. Gynecological cancers carry an even greater burden, since it's not only that we have cancer, but our disease lies in what makes us women, on the essence of our being, on our womanhood. Of course, every type has its own specifics and very delicate differences. In endometrial cancer, our disease lies in our womb. What is supposed to carry life carries death, carries undelivered dreams, missed opportunities, lost chances. It's not only cancer. It's not only the fear of death. It's also the fear of living half, empty, in shame. Was it my fault that I got cancer, this type of cancer? I was diagnosed at 45 years old, so I'm a member of a before menopause group of patients. When the first shock of the word cancer passed, I focused on the word endometrial, meaning that after the shock of death, I had to see what other words meant to me, like woman, womanhood, aging, woman in love, motherhood, and where did I stand? Right after my diagnosis, before surgery, in a conversation with my brother, he brought up the subject of family, of my own children, whether I was thinking of going through a fertility sparing process. I wasn't eligible anyway, but on top of everything else, I suddenly had to grieve for my unborn child, to realize that I might end up alone, to feel guilty that I wouldn't live up to society standards of what a woman's role is, being a mother. I felt that I had to explain a decision that even though it wasn't fully conscious at the time, it was a decision that became a reality by force, taken by life itself. I wasn't going to have any children. I was not a career woman to justify it. Then what? How could I go and guess against what society thinks is acceptable? Fortunately, I was 45, not a little girl, and able to cope with those various pressures. But deep down, to be honest, I had a little thorn in my heart. I'm not the only one that went through this disappointment. Many women found out that they had endometrial cancer at their mid-30s to early 40s when they went for a prenatal checkup, and instead of creating life, they found out that they have cancer, and the major therapy is hysterectomy. Their world is falling apart. Their relationship, their marriage could fall apart if it's not built on solid foundation. I have real life examples for that. But even if they found it by accident in their annual checkup, the shock is still as huge. We lose focus. Everything becomes black. Our dreams and hopes disappear. The future disappears. We enter a tunnel. We are scared. We feel ashamed, guilty, angry, sad. We grieve with all stages: denial, isolation, anger, bargaining, depression, and hopefully acceptance. I know I went through all those feelings. I know that when I was alone in my bed at night, facing my demons, my guilty feelings, I would burst into tears. I was feeling angry, usually towards me, frustrated. Sometimes it felt like giving up. Waking up in the morning was very hard. My cats helped me with that. They were giving me a reason to get up from bed, to make a connection with life. I'm a painter by occupation, and I had stopped to paint, to create. I couldn't see any meaning to that. I needed time to take care of my wounds, the real ones, and the unseen ones. Even though the mutilation is not seen, it's there, present. There is a hole inside us. Something is missing. Questions rise up. Am I still a woman without a uterus? Do I have a right to flirt, to love? I couldn't have children anymore. If I was going to meet someone, when I was going to tell him? On the first date? On the third? When the relationship was a little further along before that, so I wasn't too attached? Do I tell my friends? To which ones? To new acquaintance, or just to forget about it? But we cannot forget. Side effects are there to remind us. We have entered menopause from one day to the next. We cannot have children. We need to deal with the changes in our hormones, in our emotions, in our libido. Vaginal dryness, pain and discomfort during intercourse, many different psychosexual disorders, having to find other ways in order to make love that also may bring discomfort, living with the pressure to feel sexual again. I know young women that only the thought of having sex is discouraging. Incontinence makes you feel so sexy having to wear a diaper. Even fatigue and the knowledge that you cannot function like before make us want to quit. And some women have even worse side effects. They might have a stoma, they have lymphedema, fistulas, or so many others. Our body image is changed inside and out. So it's not only when to talk about our condition, when to reveal our secret. We also have to somehow manage those changes in our bodies, and so we can feel desirable again. And suddenly we age. Our skin ages, our organs age, our body ages before it's time. Will anybody love me like this? And don't get me wrong, the best wish after diagnosis is to get older and to be well, but aging from one day to the next is not easy. Where a woman stands in society, what her role is, even in in our modern times, or to countries that we believe are progress, is not as we would like to believe. There are many things still taboos or even cliché. Due to our disease, changes have occurred in our bodies and in our psyche, and we're afraid to talk openly about it. We are trying to protect ourselves from criticism, from blame, from hostility. We end up trying to explain the unexplainable, first of all to ourselves, since we carry those ideas inside us. It is us that need to accept ourselves as we really are, with our scars, with our missing parts, with our disease. We are not only that, we are a lot more than that, and we need to accept our new reality, to take care of us, to find our balance, to redefine ourselves in society, in our family, but most important, in ourselves, to love us more, to learn to live with the emptiness inside us, to listen to our silence, to make sense of our existence on another basis, perhaps even more meaningful, to invest again in life, in creation, in growth, to invest in love. 2 more publications show that we need the help of our family, of our friends, of our peers to overcome what we feel. During my journey, I wasn't alone. I tried to find support. I had support from my family, which was great, and it was a very difficult journey. When I reached the 5 years plateau, I was crying all day for a few months. I realized that all those years I was keeping my breath in fear that something else was going to happen, something bad. And because I was finally relieved, I could not stop my tears. I am, and I was doing therapy all this time. I never stopped seeking for the help and support I needed through art, through seminars, through patient support groups, through connecting with other people, with other women. We need to find the courage to ask for help, the power to speak up, to listen to other women in need. And this is the reason I decided to found my support group for gynecological cancer patients in 2016, when I was feeling strong enough to meet and support other women with the same disease. At the moment, we're about 100 members, not many because it is difficult to talk about it. But we continue and we try to bring the women who want to take that extra step together, to share our experience, our fears, our wisdom, our thoughts, to take care of each other, to find solutions on living with cancer, to ask for the right doctors, to ask for the best treatment available, to be educated about the side effects and the better management of our life after diagnosis. We offer psychological support when needed. We want women patients to know their rights, but mainly we want to feel women again, that we are not alone and that we can speak openly about our disease. Looking back in my life, I see that now I'm a lot more productive and fertile. My life is more conscious. I'm more real to me. I'm present. I did create a symbolic womb where my ideas, my concepts, my feelings can be protected, can be nourished, can be developed and flourish. I speak out a lot more and louder. Sometimes it's hard, even especially when I'm looking back as I did now, but looking back makes me stronger. Sorry. I can look back into the future with hope. It isn't easy, but I can do it. The idea that I might make even one woman feel better about herself after a gynecological cancer diagnosis makes me very happy. Thank you.
Thank you so much, Maria. Thank you. This was a very powerful presentation you gave, and very, very recognizable for all the patients that are listening, I think, because you're like talked about a lot of things we all come across during diagnose and definitely after diagnose. And thank you for all the beautiful pictures, the paintings that you have. We always see them a lot, of course, but it's really nice to see so many of them in a row. You also kind of compliment somewhere in there in the chat about that. Yeah. First of all, we didn't have any questions yet, but that's probably also because I did not invite people to ask questions. You can ask questions in the questions session. So you can still do that also for Maria, and just write down who you want to ask the question to, so we know who to ask. I just have one question for you, Maria. Do you feel that, like all the things you've mentioned, do you feel like doctors are aware enough of all the other things, beside really the medical problem, but all the other things that we come across?
I think it's kind of up to us to make them realize all the other things that we come across, or the other problems that we might have. With my doctor, he was one time he didn't see me well. He told me, I think you need to see someone. He offered me that there is that I should try and find help. And I believe that we need to tell them, even for practical things. It's up to us to tell them and make them to be more aware of what we're going through.
Yes, you're right. And I think us is especially us patient advocates, right? Our patient advocacy groups, because when you just got the diagnosis, you're usually not, you know, that's not the situation you're in to do that. Yes. Well, thank you very much, Maria. I think we need to move. We could have talked a lot longer, but we need to move on to the next one.
I would like to ask one.
Yes, well, I wanted to give you the word, so just go ahead, Philippe.
Yeah, Maria, thank you very much for your presentation and what you live, because that's very emotional. You present it on a way where, as a physicist, we are very sensitive to what you said. I have some question about what you said, because that raised many comments in terms of management of the patients. From your side, as a survivor from endometrial cancer, what is most urgent in terms of management that is lacking with the connection with the physicist? Because you mentioned, for example, your age. 45 is very young. You told that it's not so young, but it's very young. You know that in the new recommendation from the ESGO, for example, we push to the ovarian preservation, even outside from the scope of the preservation of the uterus for fertility-sparing surgery. But what is your feeling specifically for endometrial cancer about what is lacking, a big gap that is not there and that we need to work on?
I think what we need to work on is basically that, you know, we're not an organ that is diseased. We are a whole person. So there are so many other things that that we are, and especially, you know, even with having your family, if you have a husband, a companion, or somebody that, you know, might go away after diagnosis, because that is happening very easily. We have to deal with so many other things as well. And yes, of course, the first thing that you want is to survive. And that's the major thing that we have to look. But if we are well all around us, that will make that easier. That it will be, you know, the process of therapies will be easier if all the surroundings are better. So I think what is lacking is the connection between the disease and the surrounding of the patient.
Yeah. But do you feel that there is a specific request for endometrial cancer survivor compared to ovarian cancer or cervical? Because the epidemiology is not the same, the history is not the same, the focus is not the same. There is a specific group for endometrial cancer. What is your feeling about it, and what is the specific request for this group of patients?
Yeah, actually, I think because with endometrial cancer, as I said, it was usually they were older women, so it was like, you know, that's okay. You know, you can go home, and that's. But now, like I'm 58 now. I'm very young. I feel younger than I was 40.
Very young, yeah. Maria. Very young.
I feel younger than when I was 45. You know, more active. So for me, it's crucial to make plans. And like I'm thinking of going and to do a master's degree now, which is like 4 years. So and that's, you know, it's so optimistic, and that's what we need to have now with ovarian cancer, because, you know, it's usually they have therapies all the time, so they are is a very difficult cancer. They are more
chronic disease that's potential one.
It's something, therapies are coming out all the time, new therapies, everybody's talking about ovarian cancer. It is Cinderella story. Endometrial, it is Cinderella story. It's like you are there by the fireplace and nobody really cares about you. I mean, you are there, but you're not in the center. And as I said, we want to go to the ball now. We want to be part of life, in the center of life. And with cervical also, it's because they are younger. Many times they have a therapy and they forget. They don't want to talk about it, since if they don't have a hysterectomy, if it's earlier in the disease, it's a stage, early stage. Maybe they will not want to talk about anyway, and not to have any connection with other women, because they want to forget it. They want to put it aside. So it is a difference on how women pursue their disease. And of course, with vulva, as I said, and they're all out older than and sometimes they just have forgotten about their womanhood. So they don't want to talk about it at all.
Thank you, Maria, and thank you. I had the same comment than Kim. Congratulations for your paintings, because it's also a way to express your feelings and your way to live. Just a question: you paint before to be sick, or being sick, and after?
Okay, I was painting before. I have done art school in Greece. That's my studies. And I do paint now as well. So paint is even though I have stopped during those 5 years, I didn't paint almost nothing. Now I'm back into action, and I'm doing. I was always doing things with my hands, but now I'm painting again. So yeah.
So thank you very much, Maria. So we can move to the second talk with Artem. I'm really pleased to have Artem on board today. Artem is a very close friend of mine. We know together since a long time. We were in the council together a few years ago. We met 1 decade ago, and we have different meetings together around the world, in Egypt, in different countries. And I'm really pleased to have Artem, which is the chief of Gynaecology in Yerevan, in Armenia, and a big expert of radical surgery and complex management of patients. And we are really in this topic with this very difficult presentation about how the medical status of the patient could influence the theoretical way that we should treat the patients. That's a very specific point in endometrial cancer compared to the other one. So Artem, I'm really pleased to have you on board.
Thank you very much, Philip. Thank you for introducing my humble person to this. So my topic is the medical risk factors of endometrial cancer. I want to change the slide. Okay, so let's have a look on the data. We, as oncologists, we used to speak about the disease-free survival or cancer-specific survival of our treated patients. And we are very happy because for us, for gynecologists, usually the endometrial cancer is probably the easiest disease that we usually deal with. But today, we were witnessing how this disease can stigmatize the survivor, how the treatment can stigmatize. And if we have a look at the data, we see that almost half of the endometrial cancer survivors are dying from other diseases. And 20% of them, they are dying from cardiovascular diseases and diabetes. This is the data. Currently, we have very new things coming to the treatment and management of endometrial cancer. This is the new classification of endometrial cancer. Here you see the graph. It's for medical professionals. I don't really know who the audience are. Are those medical professionals or are those advocacy team members? But nevertheless, this is a very new classification, which is the base of the treatment of our endometrial cancer. And in this classification, we see the 4 general types of the endometrial cancer, and 3 of them have some specific genetic mutations behind. But the biggest portion of the patients, those are the non-specified molecular profile endometrial cancer, which is prevalent type, about 64% amongst all the patients with endometrial cancer, and it doesn't have any a specific genetic mutation behind. At least we don't know about any mutation of this big proportion of our patients. Shall we speak about this? Yes, of course, because if we take away, papillary serous cancer, clear cell, mucinous, squamous, and others, we see that low-grade, hormone-sensitive, non-specific molecular profile endometrial cancer is the population of about 87% of our patients. It's huge. It's the majority of our patients. And of course, we have to speak about this. Let's have a look on the pathogenesis. In the old medical literature, the endometrial cancer was called the disease of nuns because the practitioners have found the relationship between the parity and the endometrial cancer in that old time. In modern times, this disease has also a nickname. It is called the disease of civilization, because if we look at the statistics, we can see that globally, cervical cancer is the world champion in terms of incidence. But in countries with high human development index, endometrial cancer is the most frequent one, according to the global statistic data. So let's have a look on this graph demonstrating the causes of unopposed estrogens which lead to endometrial cancer. And let's discuss which of them are preventable, which is not. Iatrogenic estrogen therapy, can we prevent it? Yes. Perimenopausal disorders, can we prevent it? Yes. Obesity, can we prevent the obesity? Yes, we can. Polycystic ovarian disease or syndrome, can we prevent it? We can treat it. The only, these functional tumors, hormone active tumors, we cannot prevent, but we can treat and prevent the 4 major, cases of unopposed estrogens that affecting the endometrium and causing this type of the disease. How can we prevent? Let's discuss the key points of the prevention strategies. The first and the base of the pathogenesis of this disease is the metabolic syndrome. Even the polycystic ovary syndrome is a part of the metabolic syndrome. What is the metabolic syndrome? It's a group of 5 conditions that can lead to heart disease, diabetes, stroke, and other health problems. Metabolic syndrome is diagnosed when someone has 3 or more of these risk factors: high blood pressure, low levels of good cholesterol, high levels of triglycerides in the blood, large waist circumference of apple-shaped body, and high blood pressure. So those are, the key points that we can influence, and to prevent this disease. And what the therapy we can use to prevent it. The Mediterranean diet is a primary plant-based eating plan that includes daily intake of whole grains, olive oil, fruits, vegetables, beans, and other nuts, herbs, and spices. Other foods like animal proteins are eaten in the smaller quantities, with preferred animal protein being fish and seafood. The next is the dietary approach to stop hypertension. What is it? It promotes the consumption of vegetables and fruits, lean meat and dairy products, and the inclusion of micronutrients in the menu. And the next step, not next point, and we have to take care of the glycemic index of the food, because we eat, our patients eat everything, but the food with the low glycemic index is very good to prevent the obesity, to prevent the metabolic syndrome, and to prevent this estrogen aggression on the endometrium. And the high fiber diet is also very important for those patients. Therapy. The next step is the exercising, because people, use the cars, they work in the offices. Now the majority of them working, in the house in front of laptop. It's not good. Bariatric surgery and liposuction works good for these cases. Prevention of the type 2 diabetes, metformin, and treatment of the metabolic syndrome, oral hypoglycemic agents, cardiovascular risk reduction, etc. Those are the points to prevent and to treat the metabolic syndrome, the obesity, and this estrogen aggression on the endometrium. What we can do to prevent. Sorry. And so the next topic is for the doctor. What about the perioperative management? Because again, if those patients are, are the majority of our endometrial cancer patients, we see those patients, we treat these patients, we manage these patients, how we do it? It is very important to treat those patients in the multidisciplinary hospital, because we have to comprehensively control the keep on glycemic, to make a glycemic control, adjusting or holding hypoglycemics and insulin before the surgery, prior to surgery. So we need to have the endocrinologist at the day when we start to work with these patients, because some of them need more or less long treatment and pre-rehabilitation prior to the surgery, and start them standardized insulin infusion protocol for perioperative glycemic control. It's a job for endocrinologists. They know this well. They control the insulin, and they do. And they work with this patient, and it is important to manage those patients in multidisciplinary settings. And other specialists that we need for those patients is the cardiologist at the multidisciplinary hospital, because they have to take care about the heart, because many of those patients have the hypertension, they have some heart problems, etc. So this is why the cardiologists have to optimize the blood pressure, prescribe the beta blockers and other antihypertensive medications, etc. This is what we do prior to surgery. We stabilize the insulin, we stabilize the blood pressure, stabilize the heart to minimize the risk, because for every surgeon, there are, two big groups of surgical risk: manageable risk and unmanageable risk. And prior to start the surgery, we have to manage and minimize all the manageable risk before we start the surgery. Of course, in more or less, normal time. And the last thing that we can discuss here is the intraoperative, management, how we should operate these patients. Now we are very lucky because today we have the minimally invasive surgery like laparoscopy or vaginal surgery or robotic surgery. This is the big opportunity for this group of patients, because for this patient, the laparotomy is sometimes it's a disaster in terms of wound healing and other things. This is why you see here, we show the technique for laparoscopy in these patients. A minimally invasive surgery reduced the postoperative complications compared to open surgery, shorter hospital stay, faster recovery, minimize the risk of cardiovascular disease. And today we learn to not to take out the whole lymph nodes, we take out only the sentinel lymph nodes, which is minimize the traumatization of the patient also. Those are the three main, aspects of the medical risk of the patients with the endometrial cancer. And thank you very much for your attention. Now I'm ready to answer your questions.
Artem, thank you very much for your presentation.
Thank you.
You cover all the two major topics, with the first one being related to the prevention of the disease with the metabolic syndrome, and the second one to the perioperative management. That's sure that the minimally invasive surgery changed the landscape, reducing the morbidity of the surgery itself. Do you think that you mentioned it in your presentation? Do you think that the question of anesthesiological specific management could be quite complex in patients with high risk of chest mobilities? Do you think that that specific training or you need to organize a centralization of care for very high risk patients? In real life, it is what happened in many countries, I think so. But what is your feeling about it, Artem? Because it's between the training of the teams and the centralization of care for our risk patients.
Of course, Philip. In terms of the anesthesia, I would recommend to send your anesthesiologist to the group of people who is doing the bariatric surgery. In our hospital, we have such a group, and they interact together. So I'm very happy with this, because I never, have any problem with the obese patient and turn the lumbar position. They could work very good. And of course, the key for any cancer treatment is the centralization, because we almost never have a patient without a comorbidity. We almost never have a patient, with standard situation. This is why the centralization is very important, not only in terms of anesthesiology, but for example, if you don't have, in your hospital all the facilities that you need, it's not possible to treat these patients. I completely agree with you.
Your response is really pivotal, Artem, because I just want to explain to the patients that are there during this webinar that that's a specific characteristic of endometrial cancer patient. For sure, we have also high-risk patients in cervical cancer, in ovarian cancer, in terms of age, in terms of cardiac comorbidities, but it's less frequent that for the case of endometrial cancer. And just for your knowledge, if you are not skilled with the technical issue that you have as a surgeons, we tend to push all the case for mini-invasive surgery to avoid scare morbidities and to avoid extended days of hospitalization. So with the mini-invasive surgery, you can have a 1 day of hospitalization and leave the hospital the same day than the surgery. So it's a big progress. But on the other hand, when you do mini-invasive surgery, you are doing whatever you use, robot or laparoscopic approach, a pneumoperitoneum. A pneumoperitoneum is meaning to put some gas in general anesthesia in the abdomen to expose all the organs and to make feasible the hysterectomy and removal of the ovaries. And when you do that in an obese patients, you increase the pressures on the chest, and you can have some very, very difficult tolerance of the pneumoperitoneum on the chest morbidities. This explains why it is usually done by very trained anesthesiologists, not only surgeons, but also trained anesthesiologists. And the robot helps us because you can decrease the pressure of the pneumoperitoneum and so increase probably the tolerance of the chest. But it's just to explain you what is the complexity really specifically for the endometrial cancer management between what we dream and between what patients can tolerate in terms of feasibility of the surgery. What is the reason there is a comorbidity with endometrial cancer patients? That's a good question. Do you want to answer, Artem? It's your topic.
Sorry.
What is the reason there is more comorbidities with endometrial cancer patients?
Okay. As we have spoken in previous slides, the endometrial cancer, at least this type that we discuss, hormone-sensitive, low-grade, non-specific molecular type. It is not the disease, it is the symptom of the metabolic syndrome, like blood pressure, like diabetes. I consider this is the symptom. This is why the majority of these patients come to us with the metabolic syndrome. What it means high blood pressure, cardiac problems, obesity. This is why we have to deal with all those comorbidities.
And the other, if I may, Artem, the other reason is also an endocrinological reasons, because when you have some morbidities, you have an increased rate of estrogens. And estrogens is also a risk factor for developing the high level of estrogens, is also a risk factor of developing the endometrial cancer. So it's the double explanation of your question. There is another question.
Thank you. Yeah, there's two more questions.
Yeah.
Go ahead, Philippe.
Yeah.
I think Susanna just put one in there. Just go ahead, Philippe.
Excuse me?
Just go ahead. There are two more questions.
Yeah. The first question, is there a link between the risk of endometrial cancer and the previous history of liposuctions?
I think no, the liposuction can decrease your risk to get the endometrial cancer. Because if we consider that, we can speak about the biochemistry a bit, What is the unopposed estrogens? This is the, aromatization of the steroids in the fatty tissue. The more fatty tissue you have, the more estrogens you have, except of the ovaries. And so once you take out this fatty tissue, you take out those unopposed estrogens from your body. and so that you are, of course, on the lower risk of getting the endometrial cancer. So if you want to lower your risk of endometrial cancer, so work on your weight and take care about your insulin resistance.
Another question, Artem, do you want to ask to Artem the question, Kim?
Sure. It's a question from Ilona. Are the risk factors the same for having endometrial cancer and for having a relapse when you have been treated?
Can I see the question? Can you come again? Sorry.
Sure. The question is if the risk factors are the same when you have endometrial cancer and for having a relapse when you already had your treatments.
I don't think so. I don't think so because it's hard to answer the question. You know? I think of course the estrogens may play the role, but you know the risk factors for getting relapse are so there is a plethora of risk factors to get the relapse of the endometrial cancer. This is the lymphovascular invasion, this is the stage of disease, you know, this is the quality of surgery, it's a quality of post-surgical management, etc., etc. So I would say that if we scale the risk factors of getting relapse after treatment of the endometrial cancer, those risk factors like a metabolic syndrome, I mean the obesity, hypertension, and the diabetes, those are the last. I think those are the last in this row. Why? Because if we go back to the first slide, we can see that 50% of those patients, of the survivors of the endometrial cancer, they do not die of the endometrial cancer. They're dying of the disease caused by this metabolic syndrome, obesity, cardiac problems, diabetes, cardiovascular diseases, etc. That's my opinion.
Anne asked a very, very important question, if I may. Thank you, Anne, because what we said with Artem, what is explaining Artem is the physician point of view. It's not to give to the patient the feeling of guilty, of shaming, of responsibility in the disease. So it's just to explain. That's a very good question, Anne. Thank you for raising this problem. We are just trying to explain how the specific management of endometrial cancer is complex because we have comorbidities. Some of them are not the fault of the patient at all. They are not responsible of that. And they can impact the management of the patient. But what we learn in time during the 2 or 3 last decades also with that is that we complexify the management because patients could be old, could have comorbidities, and also on the other hand, we simplify the treatment and the surgical treatment. And for example, the full lymphadenectomy is now disappearing compared to what we did 10 years ago. So that's a good sign. So it's also linked with your question, Anne. The patient should not be shame, who should not have the feeling of guilty because they have endometrial cancer, because it's the natural history of each of us to develop cancer without any responsibility for that. But on the other hand, we have a specific care in this group of patients due to the risk of the management, not related to the guilty or to the shame due to this risk.
Yeah, so then the question is, maybe Anna, you can just ask yourself, so how do we carefully communicate it, right? Because we know that that it is a risk factor, but how do we communicate with patients? Because that's basically your question, right, Anna? You're muted.
Yes, indeed, because if this is not really communicated very carefully, the patient will look for the blame by herself. That's for sure.
I agree with you, Anna. If I may, that's a good player for centralization of complex care. And in fact, in real life, it is what happened, because you saw that the ESGO classification, the FIGO classification change, integrating molecular classification. And so now, de facto, the endometrial cancer patients, which is the most frequent cancer. I just remind you that among the gynec cancer in Europe, it is the most frequent, is centralized in centers when we can use molecular biology to classify the disease. And it's also this center that can manage fragile patients, if I may, or at-risk patients. So that's a good evolution of the management of the patients. But we are not here as a physician to raise the question of guilty or shame. It's just the overall management of the patient and decrease the morbidity of the treatment. This is the key issue.
Okay, thank you, Philippe. Maria, you had a question.
Yeah.
You want to ask it yourself?
Yeah. You know, when I was diagnosed in 2011, I did research, and I have my brother who lives in the States. So we saw Sloan Kettering, what they are doing there. And actually there, when you had surgery, you had your hysterectomy, they were doing liposuction as well at the same time. So when after that, you didn't have all the fat, all hormones of to start fresh, kind of. Is that something that is happening? I mean, how do you feel about that? Is it something that it's good to do? It's happening in Europe?
Artem, do you want to reply?
Yes,
Yeah.
yes, it is. It is very common in our practice. Just 2 weeks ago, I did a surgery on a lady who had a 15-kilogram paniculum, you know. I had the pictures, I didn't include them. And we did this paniculectomy. We took out all this, you know, panis, all the fat from the abdomen. And then we easily put the trocars and did our job, and it was okay. So it is a very common, and it's very good for the patients, because, you know, it is enhancing the surgery, it is enhancing the post-operative recovery, and it is the pathogenically good for this disease. So it is a very common approach, at least nowadays in Europe. Yeah.
Thank you.
Thank you very much. I think this, do you want to say something, Philippe, at the end of this?
No, we can move to the next speaker, Kim, that you can introduce if you wish.
Sure, okay. Yes, so the next speaker is Houssein El Hajj from France, and he will be talking about genetic risk of endometrial cancer and prevention. Let's go ahead, Houssein.
Hello, everyone. I'm very happy to be here. Thank you for the invitation, and I would like to congratulate Artem and Maria for those super presentations. So for my turn, I'm going to talk about genetic risk factors and preventive measures. So if we start to look at the word map, we can see that endometrial cancer is most frequently present in Europe, in the United States, Canada, and same goes for mortality. So this is why it's an important topic. So if you want to understand when we talk about genetics, if you look at this picture, okay, so to have a cancer, so a cancer can develop, we need genetics, we need environmental factors, and all of this will work together to eventually produce a cancer. To simplify things, when we have less genetic factors, we will need more environmental factors. And when we have more genetic predisposition, we will only require just a little bit of environmental factors to produce cancer. So I will start with a question without before proceeding. should we perform endometrial biopsy as a routine screening or no? This is the second question that's on the poll. Yeah, thank you. Okay, so most of those who responded said that in some cases, to which I completely agree. So why am I talking about this today? Because even for women at increased risk, routine screening is still not advocated. However, there's one exception, that's women with Lynch syndrome. So this is what we will be most
Okay, sorry for this technical mistake. It was not on our side. It was someone opened another Zoom meeting and canceled ours. But we are back in. Even some of the attendees are already back in. So I'm restarting the presentation in a bit, and we will get back to the point where you ended, Houssein. Okay?
Thank you.
I'm once again sorry for what happened. It was rather unexpected. Okay. Give me a second, please. Do it this way. Where do you end? How frequent it is?
Yeah, perfect.
Okay, I will give you control over the slides.
You tell me when we're back.
Yeah, you can continue.
We're online? So I don't have control. So sorry for the technical issue. Now we're back. So I will resume from where I just left. Why are we talking about this? It's because this is the exception. Okay, so in general, we do not need to do endometrial biopsies except for this case. How frequent is this? Most endometrial cancers are caused by random non-hereditary mutations, but most of extracolonic manifestations of this Lynch syndrome are endometrial cancers. So this Lynch syndrome, the most frequent cancer it induces is colon cancer. However, the second location after colon cancer is endometrial cancer, and it usually starts 10 or 20 years earlier than in general population. It only represents 3% of all endometrial cancers. And then, if you remember, Artem spoke about certain subtypes of endometrial cancers, and this represents 10% of them. So it is not very frequent. It's actually rare, but it's important to know. So what is this Lynch syndrome? It's transmitted via germline mutation. It's autosomal dominant. And then there's a problem with the DNA mismatch repair genes, and it increases the risk of cancers for colon, endometrial, ovarian. And it has a 71% lifetime risk of developing endometrial cancer compared to 2.7% in the general population. However, here, if you can see, so This is the Lynch syndrome, and this is the risk of cancer that it induces. Okay, we can see colorectal, we can see endometrial, and then other cancers, but they are less frequent. But let's talk about those terms. What's germline mutation? It's simple. If you can look at this tree, we can see a left side and a right side. When we talk about germline mutations, we will talk about mutations that exist in the sperm and the oocytes. So our parents had them within the sperm or oocytes and precursors, and then they can pass them down to the children. So they will affect every cell in the body. This is why, as you can see here, all the flowers in this side of the tree are alike. And they look alike because they were transmitted by the gene. However, if you compare, and then this tree, this side of the tree will transmit it to others. However, somatic mutations is the other type of mutations, is actually sporadic mutations that occur in any of the body cells and where the environment plays a role. This is why we will have all kinds of mutations, because it was not transmitted genetically. It actually was acquired during a person's life. This is why we go back here. When we have a lot of genetic factors, we only need a little bit of environmental factors to induce cancer, and vice versa. So this is very important to keep in mind. What's autosomal dominant? Autosomal dominant, it means that if a parent is a carrier, he will transmit it to half of his children. And when this character is present, so it will manifest, compared to a recessive trait, which will not manifest. So one single gene can induce the disease if it's autosomal dominant. And then we will move to another complicated expression or term, DNA mismatch repair genes. What is that? Let's imagine all the cells of our body are multiplying. So and are copying each other. So each cell will give 2 copies that are exactly a copy of the main cell. It's exactly like if you are asking a printer to print thousands or millions of papers every day. Well, we have all been there. We will have jammed papers, we'll have papers that will get stuck, and it will be complicated. What we will do, we will call the IT guy to come and help us repair those papers. We would expect that in a normal situation, this IT guy. However, if we have a genetic mutation, we will end up with this IT guy who doesn't know what he's doing. And we'll end up with a lot of papers that are of bad quality and jammed. And this way we will have cancer because we will have an accumulation of bad genes and bad cells. This is a small video that shows exactly what I was saying. So when we have a multiplication of a cell, we can always have problems. When we have problems, we will have those genes, okay, that constitute the Lynch syndrome. They will come together to create a sort of device that will come and repair the jammed paper. However, when there's a problem, those genes cannot constitute this device, and then you will see here, they will try to associate, but then the device is not working well. So we will have an accumulation of genetic mutations that will eventually lead to cancer. And the genes that are responsible for correcting the mistakes in the DNA are those MSH2, MLH1, MSH6, and PMS2. When we have mutations, it causes either abnormal protein or missing protein or gene silencing, and this will induce an abnormality in the device that should correct any DNA problem. And those are the most frequent genes. After that, this Lynch syndrome, it accounts for, as I said, 2 to 5% of all endometrial cancers. We spoke about this, so I will move further. When we talk about clinical presentations, it is exactly the same as a non-Lynch syndrome. and the majority of the patients are diagnosed at early stages. However, there is one thing related to uterine location. In general, when we have normal endometrial cancer, it is mostly localized in the corpus uteri. However, in the Lynch syndrome, it's most likely to be present in the lower uterine segments and sometimes can be misdiagnosed with cervical adenocarcinoma. And the endometrial type is the endometrial histology, just like sporadic endometrial cancer. Here we can see, so in regular endometrial cancer, the disease starts here. In Lynch syndrome, it can start here, but it is more likely to start here compared to sporadic endometrial cancer. And if we go and do laboratory testing, this is where we do the MSI and MMRD. And if both are negative, so those tests are recommended for all endometrial cancer patients. And we either perform them on the endometrial biopsy or on tumor tissue. And if the MSI test is positive, then we have a microsatellite high instability. And if the mismatch repair test is positive, then it is a DMMR, which means that the device, the repairing device, is not functioning well. If both are negative, then we don't have this problem. I will go further. So what do we do if we have a Lynch syndrome? If the Lynch syndrome is diagnosed, we should inform the patient of the increased risk of endometrial cancer. We should refer her to genetic counseling to check her and her descendants, her children, and then we should tell her to seek medical attention in case of abnormal uterine bleeding. And if there are any symptoms, we should definitely do an endometrial biopsy. And if there are no symptoms, we should start having annual sampling starting the age of 35 years old. Even if she does not have symptoms, we need to biopsy the endometrium every year. And the biopsy could be performed either using the pipelle of Cormier during consultation, which is a small cannula that we introduce in the uterus and we aspirate to have a biopsy, or via hysteroscopy if we have any suspicion of lesion, and which can be done in the operative theater under general or regional anesthesia, and usually it's a same-day surgery. So you go in, you do it, and then you leave the same day. So now the second question, is risk-reducing hysterectomy recommended for endometrial cancer? Okay, so hysterectomy is only recommended. Most of the people agree that only in some cases, which is completely true. So as I said, surveillance would be annual transvaginal ultrasound and annual or biannual biopsy until hysterectomy is performed. Hysterectomy and bilateral salpingo-oophorectomy will prevent endometrial cancer and ovarian cancer because Lynch syndrome is also associated with an increased risk of ovarian cancer. However, we cannot say that it completely prevents ovarian cancer because this is a small parenthesis, but because ovarian cancer is a family of disease that includes ovarian, tubo-ovarian, and primary peritoneal cancer, but it reduces both ovarian and tubo-ovarian cancers. And when do we perform hysterectomy? We do that after completion of childbearing and preferably before the age of 40 years old. Patients with Lynch syndrome who undergo surgery for treatment of colorectal cancer should be also offered concurrent prophylactic hysterectomy and salpingo-oophorectomy, which means the removal of the uterus and the ovaries and the fallopian tubes. However, this decision needs to be individualized, taking into account the patient's childbearing plans and prognosis. And we should discuss with her the pros and cons of prophylactic surgery, including the risk of if we do that, we might sometimes find cancer within the uterus or the fallopian tubes or the ovary. Even if our ultrasound imaging was completely negative, even if our preoperative assessment was negative, we might find gynecological cancer. So we should evoke that. We should talk about that. And we should also talk about estrogen replacement therapy if we perform bilateral ovarectomy. If a childbearing project is not complete, but the patient is not trying to conceive yet, we can do a risk-reducing hormonal contraception and surveillance. We can either give estroprogestative contraceptives that will reduce the risk of both cancers, endometrial and ovarian, or only progestative contraceptives that will reduce the risk of endometrial cancer. However, this is not an alternative to surgery, which means that at a certain moment, it is recommended to perform the surgery. What is the preoperative assessment for prophylactic surgery? We have to check that we don't have cancer, so we would do an endometrial biopsy, we would do an ultrasound, we'll do a baseline cancer marker, and we will do an appropriate non-gynecologic cancer screening, especially for the colon. Intraoperative procedures, as Artem and Philippe said, minimally invasive surgery is preferred. We will carefully assess uterus, ovaries, and the bowels. The pathologist should be advised of the high risk of cancer. If you have any suspicion of cancer, we would do frozen section. Frozen section, it means that we send the specimen right away for direct analysis, and we will have an answer during surgery. And then the surgeon should be prepared to perform any additional surgeries in case of diagnosis of an occult carcinoma that was not detected previously. After surgery, once we perform the hysterectomy, there will be no need to perform any endometrial cancer surveillance. The patient will have annual pelvic examination, annual transvaginal ultrasound, and an evaluation of the CA-125 level to check for ovarian cancer, because here in this case, we did only hysterectomy. However, if we remove both ovaries and the uterus, we will only be screening for the primary peritoneal cancer, as I said. It will be only annual pelvic examination with evaluation of the tumor marker. For the moment, we have not screening is also an option, but we have to explain to the patient that whenever she has any symptom, she needs to come and see her doctor. I will just talk fast about two other syndromes that are much less frequent, Cowden's syndrome and Lee-Fraumeni, that induce also uterine cancer, but they are very, very rare. And what are the take-home messages? So we have to identify women at high risk to target prevention. We have to perform systematic analysis for those genes in all endometrial cancers to identify individuals that require surveillance for other cancers, notably colon cancer. However, remember, it's only 3% of all endometrial cancer, and the rest is related to polygenic and environmental factors. And that's all from my side. Thank you for your attention.
Thank you so much, Houssein, and sorry for what happened during the presentation. But we're glad that we got most of the people back, and of course this is recorded, so you know everybody can look back at it. Some of the pictures you used were very interesting. So a shirtless guy is better at ICT than someone who is yellow and a little bit bigger, I guess, right? I had one question. You said that when you have Lynch syndrome, it would be better to have your hysterectomy before the age of 40. And that is, of course, if there's no children's wish anymore. Why is that?
Because of the increased risk of endometrial cancer and this genetic mutation, and then because in those patients, usually endometrial cancer starts 10 to 20 years before the general population. So if you look at the general population, the cancer will start between 50 and 60 years old, and in those patients, it will start 10 to 20 years earlier. This is why it is recommended to perform that before 40. However, this decision should take into consideration the patient's status, and especially that now we are delaying childbearing more than before. So this should be taken into account. And this is why we have other preventive measures such as hormonal therapy, which we can call, it's not chemotherapy, it's called chemopreventive measure, but it's actually hormonal therapy that can reduce the risk until childbearing is complete. And then after that, we can perform hysterectomy.
Okay, thank you very much. Philippe, do you have a question?
Yes, Houssein, is there a specific, really that's important because we focus on two different populations, the population of metabolic and the population of genetic risk. Is there a specific prognosis, a poorest prognosis when you observe an endometrial cancer in patients with Lynch syndrome, for example, or is there a specific molecular characteristics that can impact the management in case where you discover some malignancy in the uterus?
So yes, but what we will do the whole molecular classification, not only this. And then after that, when we look at other molecular factors, they can also play a role in the prognosis of these patients, especially other mutations like poly or other mutations. So those can influence the prognosis of patients.
But do the prognosis of patients having an endometrial cancer in the context of genetic risk have a worse prognosis than the other one with metabolic syndrome?
Yeah.
Yes, that's the point that I want to
exactly
with you. Yeah.
It starts earlier and it's of worse prognosis.
Yeah. The question is also the management of the relatives when you have Lynch syndrome, and what is that's quite difficult because when you are very young, outside from the scope of having children, it is the question raised by Kim. How can you have an accurate follow-up of these patients to reduce at the maximum the risk of discovering a malignancy? You are using Pipelle de Cornier or hysteroscopy, or what is the ultrasonography? What is the use that is the best combination?
So Pipelle de Cornier is enough unless we have a suspicion of a endometrial thickness on ultrasound. So what should be recommended is clinical examination regularly every year, and then to have a low level of tolerance for any vaginal bleeding. And with that, we perform a yearly ultrasound with a biopsy every year. And the biopsy should be performed only most preferably in during consultation with Pipelle of Cormier. And then if there's any doubt, then we would go and do hysteroscopy, which is still an invasive procedure compared to Pipelle of Cormier. But then there's no, when we read the recommendations, there's no consensus about that. So we can do either, but
yeah.
The problem with this is that if you do the blind biopsy, there is a risk to miss a disease.
Yeah.
And for example, recently we totally, abandoned the blind endometrial biopsies, and we prefer to do it under hysteroscopy control. It's like, if you compare pap smear and colposcopy plus biopsy, it's like this. You see the lesion and you take the biopsy from the certain area. I think the hysteroscopic biopsy is the future of diagnostics in endometrial.
So if I may add to what Artem is saying, indeed, the results of a Pipelle of Cormier biopsy is only relevant if it's positive. which means that if the result is negative, it does not mean that there's nothing, but if it's positive, it means that there's something. And this is important to keep in mind. And I think I agree with you that it would be the future, because now we are having more and more hysteroscopy that's performed in consultation without anesthesia, with soft hysteroscopes.
Yes, yes, the office hysteroscopy is a solution.
Have you specific comments or question to add among the patients that are there? Because
there's a question. Maybe if you would you mind, Philippe, ask the question? It's in the.
Yes, but I cannot read it.
You cannot read it. Okay, I'll read it. Hussein, pay attention. Hi, Dr. Hussein. I'm just going to read it. Hi, Dr. Hussein. Nice presentation and nice to meet you again. This is from Nagam Ibrahim Mahdi. You know him, I guess. Yeah. How can we decrease the risk in patients with breast cancer, those on tamoxifen treatment? Is routine endometrial sampling in an option, and do you suggest to have? Well, can anyone help me?
How to follow patients with tamoxifen treatment for breast cancer in terms of higher risk, Hussein?
So it's we do not do systematic biopsy, but we do ultrasound regularly, and then we perform biopsy if we have any endometrial thickness, but we do not perform regular sampling. I don't know if I answered the question.
I think so. I think so.
Let me see. Does anyone else has a question? I don't see anything else coming. Well, then, and it's also like 1 minute before 8:30. So I think I would like to, to thank especially Maria, of course, Artem, Hussein, for your presentations. I thank everybody for joining us, and it's really great that so many people signed up and were here. We're very sorry, for the technical problem we had. It's we can do a lot, but sometimes, things can go wrong. But it's great that you came back, and of course we're recording it, so you can watch the whole thing again. So again, thank you, Philippe.
Yes, thank you, Maria, for your presentation, because it was very important for us to have your own life and what you felt during your treatment. And thank you to Artem and Hussein for your presentation that clarify a lot of things. We hope so for the patients, and also to also your inputs as engaged patients is very important for us to improve the quality of life. I think that in terms of scientific management, we are on the top, because we learn a lot during the last years. But what is currently missing, it is what you said, Maria. We can improve the quality of life. We can improve the well-being of patients during the treatment, and reduce the long-term after effects of the disease. That's the pivotal issue that we should work on, and we are trying to work on other physicians. And thank you for your as patients to help us and to support us on this way.
Thank you.
Thank you.
So thank you very much, and have a great evening, and we will see you soon next time.
Bye. Bye. Thank you. Bye.
Bye, everyone.